And so I have the pleasure of staying at the podium for just another minute to introduce Dr. Azka Ali, who's one of our newer breast faculty. She's been with us for about a year in breast medical oncology. She did her training in Florida and joined us after that, where she has been a tremendous influence in our program. She is really focusing a lot of her efforts on the local recurrence space. So I would say she's developing her expertise there, but we have the benefit of using her clinical investigation skills across multiple disease states. And today she's going to be talking to us about metastatic lobular breast cancer.
Thank you, Megan. I know you said a year, but it certainly feels a lot longer. In a good way. So today I'll be talking about metastatic lobular breast cancer. These are my financial disclosures. This is a brief outline. In terms of background, I know we've heard already that majority of our invasive lobular breast cancer, or ILC, is treated similar to IDC or invasive ductal breast cancer, but we do know that there are clinical and pathological differences between the two histologies. And we also know the response to therapies can be very different. So what are the unique characteristics? The Great Lakes Consortium data that Dr. Cruz mentioned, it did bring up some very interesting and thought-provoking data points. For instance, we see that ILC patients are more often diagnosed at a higher stage, 20% versus 10%. There is a slightly higher incidence of de novo metastatic disease, more patients with T3, T4 disease, N2, N3, and a higher prevalence of ER and PR positivity. We also have seen that bone is a much more common site of metastasis for ILC compared to IDC, and there are more mets in ILC in the peritoneum versus IDC. In terms of biology and clinical course, I'm going to show you some slides from a retrospective review at MD Anderson Cancer Center, where they compare some outcomes between IDC and ILC patients between 1997 and 2020. This was presented as an abstract at San Antonio Breast 2022. And the investigators evaluated overall survival, OS, progression-free survival, PFS, or disease-free interval, or DFI. They identified over 7,000 patients that had IDC subtype, over 1,000 patients with ILC histology. Median follow-up was 4 years, and they noticed that patients with ILC were older, had fewer sites of metastasis. They were more likely to have a history of breast or ovarian cancer, less likely to be HER2 positive or HER2 amplified, had lower Ki-67 and low nuclear grade. In terms of patterns of spread, very similar to what we have seen in the Great Lakes Consortium data. And in terms of survival outcomes, we see that even though the PFS curves do eventually merge, there is that initial early longer progression-free survival, and that's represented in the blue line here. On the left, where we see the overall survival, we also see a advantage towards actually the ILC histology. This again is a short follow-up at 4 years, and if you look longer, it do look like the curves are very likely separating. What happens when we separate these ILC patients in terms of ER expression? And it does look like the more ER expression is tied to probably a better prognosis, as you can see in the yellow line. The next question, I think, which is obvious at this point, is what about the benefit of endocrine therapies for these patients in the metastatic setting? This is another retrospective review, also from MD Anderson Cancer Center, which compared survival outcomes in metastatic HR-positive, HER2-negative IDC versus ILC patients. And they compared outcomes in patients that were treated with CDK4/6 inhibitors, everolimus, exemestane, mTOR inhibitor, or PI3K inhibitors. In terms of characteristics, we see that they had over almost 3,000 patients that were HR positive, HER2 negative. Age, race, menopausal status, biomarkers are all balanced. Mean age is about 50 years. 10% of patients that were Hispanics, up to 9% Blacks. And we do see that the baseline characteristics remain pretty consistent, whether it's split up by patients with CDK4/6 inhibitor therapy, everolimus, exemestane, or alpelisib plus endocrine therapy. In terms of outcomes data, we see, I'm going to draw your attention to the overlapping curves with the red line representing ILC and the non-significant p-values in the next few slides. The median PFS is 11.7 versus 14.5 months, 1-year PFS seems equivalent, and 5-year PFS also seems very similar. OS data similarly is very similar numbers and non-significant p-values. This, of course, is in context of CDK4/6 inhibitors. What about patients on everolimus and ET? And once again, we see very similar numeric PFS numbers, similar overall survival, and once again, non-significant p-values. What about alpelisib and endocrine therapy? Once again, we see similar PFS, similar OS, and non-significant p-values. So what we learned from this retrospective review here is that metastatic HR-positive IDC and ILC and mixed histologies, they had very similar PFS and OS with endocrine therapy in combination with CDK4/6 inhibitors, mTOR inhibitors, and PI3 kinase inhibitors. What about response to CDK4/6 inhibitors, as we have 3 of them? This was a pooled analysis of phase 3 trials. This was done by the FDA to represent the trials that have been submitted to the FDA from 2013 to 2017. This featured 7 trials featuring the 3 CDK4/6 inhibitors. Primary endpoint in this review was PFS as assessed by the local investigator, and secondary endpoints included overall survival and overall response rate. And what we see here is in the top column, in the top table here, is that the demographics is very different. Of course, our lobular patients are not as prevalent as our ductal patients. And in the bottom chart, we see that the median PFS is actually quite similar, and these values are insignificant. For example, a 28.1-month PFS in the ductal cohort versus a 23.6 PFS in the lobular cohort. So that brings us to the next question. What is different about ILC? Because we do know that this is a different type of histology and a different cancer. In terms of mutations, as we have heard already, invasive lobular breast cancer tends to have a higher incidence of mutations. So for example, CDH1 is present in 65.4% of lobular cases. PIK3CA is about 43.3%. HER2 mutation, not HER2 amplification, 5.1%. And AKT1, PTEN, BRCA2 are anywhere from 2 to 4% incidence. When you compare that frequency of mutations to invasive ductal cancers, we see once again CDH1 is very highly represented here, and really it's under 2% for IDC patients. That's the gray curve up, the gray dot up there. And when we draw our attention to the call-out graph on the right, we can see that some of the mutations that are tied to eventual endocrine resistance, like FOXA1, ARID1A, they are more prevalent in ILC. So those are represented anywhere from 7 to 9% in ILC, however, they're only 2 to 3% in IDC patients. This is an interesting chart which basically represents a whole host of mutations, and the tier 1 here represents targets that are ready for implementation. For example, things like ERB2 amplification, germline mutations, NTRK mutations, PIK3CA. I want to draw your attention to high tumor mutational burden, and the table here represents primary ILC mutations versus metastatic mutations. And if you look at the tumor mutational burden, we can see that in metastatic ILC, that could be present in 16% of cases compared to 5% in NST or no special type of tumors. PIK3 mutations, you can see, is present in 43 to 48% of cases versus 33% in NST, which very likely includes IDCs, of course. In tier 2, we see a bunch of investigational agents. In tier 3 and tier 4 is where we see a lot of targets which are in the preclinical space, which can have a lot of interest. In tier 4, we also see a ton of mutations that are tied to eventual endocrine resistance. So the next obvious question, of course, after all that information is how do we optimize the treatment schema and how do we optimize the first line? I think when I think about evolving space in the HR-positive metastatic breast cancer, this is something along the lines of what I think about. In the first line, we're thinking of endocrine therapy plus CDK4/6 inhibitors. We do have some data in that space, of course. But what about endocrine therapy alone upfront for some patients to be followed by endocrine therapy plus CDK4/6 inhibitor? We have data from SONIA trial presented at ASCO 2023. In terms of second line, I think the targeted space is ever so important for the ILC patients. primarily because of the the higher incidence of mutation in these patients. So things like PIK3CA mutation, fulvestrant capivasertib with the Capitello 291 trial, we have seen those results in San Antonio Breast 2022. Those that don't have a mutation, what about endocrine therapy plus ribociclib per the MAINTAIN trial? And of course, what about good old endocrine therapy plus everolimus? Some other mutations that we should think about are germline and somatic BRCA mutations, TMB, MSI, and TRK ESR1 mutations. And of course, then we're left with chemotherapy and our novel ADCs. So how do we optimize first line? I think that's still an evolving question. Should all patients receive CDK4/6 inhibitor as part of first line? Should there be some who can start with endocrine therapy alone? Is there a benefit to early therapy switch based on ctDNA dynamics? Does endocrine backbone switch with continued CDK4/6 inhibitor extend first line therapy? Looking at the 3 approval studies with our CDK4/6 inhibitors, I think there's been an evolving question, are these CDK4/6 inhibitors equal, similar, or different? And I think as we're learning more and more from the survival data that has now come out from PALOMA-2, MONALEESA-2, and MONARCH-3, we are compelled to believe that they are very likely different drugs with different mechanisms of actions and very different overall survival data. We do have to remember that these are different studies, these are different study populations, different designs, and really cross-trial comparison is not recommended. That being said, there are some pharmacological differences. For example, ribociclib is a stronger CDK4 than CDK6 inhibitor. Abemaciclib has a stronger CDK1 and 2 activity. We also know that ribociclib is very active in the HER2-enriched population, and based on that, there are some trials that are being looked at in the HER2-enriched HR-positive populations. And how do we put the SONIA trial in the context of all of this? So this was a study that was just presented at ASCO 2023. These were patients with HR-positive, HER2-negative advanced breast cancer, and patients were randomized either to a non-steroidal AI upfront or versus a non-steroidal AI plus CDK4/6, and then they were allowed at progression to go to fulvestrant alone or fulvestrant plus CDK4/6 inhibitor. The primary endpoint of the study was PFS2. There are some issues, obviously. One is that we don't know what's the treatment after the second-line progression, and the physicians could use any CDK4/6 inhibitor based on the EMA approval, as this is a European study. Some demographic information, note that patients are older than our pivotal trials. Majority of these patients are postmenopausal. A third of these patients had de novo disease. About 50% had mets, and I think the most obvious glaring thing here is that 90% of these patients received palbociclib. There are a few, about 8% are those that received ribociclib, but overwhelming majority of these patients received palbociclib. PFS curves on the top right here, this is the PFS in the first line, which you can see a very nice separation and a significant p-value. But when you look at the primary endpoint, which was that PFS2 beyond that first progression, you do see that those curves come together, and that p-value is no longer significant. Overall survival curves, again, overlap. This is not significant. And when you look at the subgroup analysis in the PFS2 group, we see that there's no difference based on, when we select certain variables. Interestingly, the very last line here, there's also a suggestion of no benefit with PFS1 with ribociclib. But I think, interpret that with caution. It's a small number of patients, and those confidence intervals are really wide. So what is the conclusion? I think we certainly have more questions. Can certain patients delay CDK4/6 inhibitors? I think the big question with that, the big problem with that statement is that fulvestrant alone, the more and more we realize, is no longer an ideal second-line alternative. We have really good data with a lot of the targeted agents and fulvestrant, and I think we're not really using fulvestrant alone anymore in the second line. The other issue, I think, with this trial is 90% of these patients received palbociclib, and knowing what we know with the overall survival data, I think we have to interpret that information with caution. We must remember patient experience and financial toxicity. Perhaps there are some good risk patients with prolonged disease control that can delay CDK4/6 inhibitor, of course, based on patient preferences. We do need novel biomarkers, and improved PET imaging and ctDNA. The next question is, what is the role of ESR1 mutations, and can we track these mutations? We had learned from the phase 3 Emerald study. This was for our review, was HR-positive study in metastatic breast cancer patients, where patients are randomized to elacestrant or investigator's choice of endocrine therapy. And as our review, 70% of these patients had visceral mets, 40% had 2 prior lines of endocrine therapy, 24% had chemo, 100% CDK4/6 inhibitor prior use, and very importantly, fulvestrant was allowed, and in fact, 30% of patients had fulvestrant. And what we see here with the 6-month and 12-month PFS rate, that there is an improvement with elacestrant. And we had also learned that longer the duration of CDK4/6 inhibitor, the greater the benefit of using elacestrant in the later line. And we'd also learned that ESR1 mutation is where the difference was really seen. So once we couple the ESR1 mutants and those that had a longer progression-free survival on CDK4/6 inhibitors, those were the patients that were likely to get the greatest benefit. So what is the next step with this? We are looking forward to Elevate trial, which is a phase 1b/2 elacestrant combination with alpelisib, everolimus, palbociclib, abemaciclib, or ribociclib. This is an interesting study that was reported at ASCO 2023, and essentially what the investigators did here is they took aromatase inhibitor-sensitive patients with ER-positive, HER2-negative breast cancer, and patients were essentially treated with AI and palbo, and then the ctDNA was analyzed serially. Those who had a ctDNA-only progression, not radiological progression, some of them were either they were randomized to switch to fulvestrant palbo, or they were randomized to stay on AI plus palbo. And one of the things they look at is the PFS2 once again. What you see down here in terms of the median PFS, we do see about a 7-month advantage in PFS with this early switch approach based on ctDNA. In terms of PFS2 data, there is a suggestion of a 15-month PFS improvement with, once again, that early switch based on ctDNA alone. We are awaiting overall survival data and secondary endpoints. Other interesting things that came out of this study in terms of exploratory endpoints is that there was no difference by virtue of ESR1 mutation. It did not matter whether the ESR1 mutation was polyclonal, and we do know that ESR1 mutation clearance was an independent prognostic risk factor. So what do we learn from these trials? Emerald, we know it's the only phase 3 oral SERD trial that allowed 100% prior CDK4/6 inhibitor usage. We do know that the duration of CDK4/6 inhibitor in that first line and that PFS is correlated with improved outcomes. And with PATA-1, I think we still have some outstanding questions. For instance, overall survivor data is pending. PFS2 data is very intriguing, but we don't know what's the post-fulvestrant palbo therapy. Once again, it's a palbo study. And then ctDNA analysis, this was done serially, and we have to, I think, decide if that's something we're ready for as a community. How should we think of second line? I think a lot of that depends on understanding the resistance patterns that ER-positive breast cancer goes through before we can think about what's the next line. This is a quick review of SOLAR-1, which was a study that looked at PIK3CA mutated patients, where patients were randomized to placebo plus fulvestrant versus alpelisib plus fulvestrant, and there was a 5.6-month PFS benefit. We do have to remember that 6% of these patients had CDK4/6 inhibitor, but then BELIEVE study, which was a phase 2 study, did include patients that were post-CDK4/6 inhibitor progression, and that had some pretty good outcomes as well. What is coming in this space, I think this is very exciting. We are seeing more and more molecular targets in this space, and I think it's going to become very relevant for our metastatic ILC patients. We have talked briefly about alpelisib. I think the dual PI3K mTOR gedatolisib has very interesting phase 1b data that was presented at San Antonio Breast 2022. We have seen some data on capivasertib, BLAST, San Antonio Breast, and ASCO in form of Capitello 291, and I think we await some of the other trials. A quick review of Olympiad. This was a G-BRCA study where there was a PFS benefit seen, but not an overall survival benefit. And then what about HER2 mutations? As I just showed you guys, that there can be about a 4% incidence of HER2 mutations. So once again, these are not amplifications, these are ERB2 or HER2 mutations. This was looked at in the SUMMIT trial, where patients were HER2 mutant and they were split up into 3 cohorts. And I want to bring your attention to the very right here on towards the overall response rate. And what you see here is with the triplet of neratinib, fulvestrant, trastuzumab, a 38% response rate was seen in those patients. Those who were on the fulvestrant trastuzumab doublet had a low response rate, and when they progressed, were allowed to go on the triplet, and they were able to see a 25% response rate. And then the patients that were truly triple negative, there was about a 30% response rate with neratinib and trastuzumab. We also shouldn't forget about the tumor agnostic studies that we have and some very good response rates that we have with MSI high patients, TMB 10 or more, NTRK fusions, and RET fusions. So what are the future directions? I think particularly related to ILC, Gelato study I think is going to be very interesting. That's going to look at the efficacy of carboplatin and atezolizumab in metastatic lobular breast cancer. And then Rollo study, which is looking at crizotinib in lobular breast, diffuse gastric and triple negative lobular breast cancer, or CDH1 mutated solid cancers. Once again, I'll leave you with this, and I'll be happy to take any questions.